Understanding alignment is important to achieve the twin goals of long survivorship and good function. In an ideal world, a well-aligned knee should function very well for many years to come. Unfortunately, in the real world, these twin goals of survivorship and function seem to work at cross purposes. Let us try and understand the basic principles of coronal plane alignment so that we can set our targets to achieve the twin goals of survivorship and function. The topics covered in this presentation would be the reference axis on which different alignments have been described, the various described alignments and their strengths and weaknesses, and lastly, the 3D effects of coronal plane alignment variables, the varus and valgus. Amongst the various reference lines that we will be looking at are the combined hip-knee ankle axis, individual axis of femur and tibia and their angles, and joint line orientation. Let us begin with the hip-knee ankle axis. Hip-knee ankle axis is the line joining the hip center, knee centers of femur and tibia, and the ankle center. Normally, it is one single line. Femur mechanical axis is defined as the line joining the hip center, which is represented by the center of femoral head, to the center of the knee on the distal femur. Femur anatomic axis is defined as the mid-diaphyseal line through the femur. Femur knee joint line. The distalmost points on the medial and the lateral condyle of the femur are marked. The line joining them represents the femur knee joint line. The angle used for measurement between the mechanical axis of the femur and the knee joint line is the lateral one, and hence is called the mechanical lateral distal femur angle. The knee joint line is in 2 to 3 degrees of valgus to the perpendicular from the mechanical axis. The angle between the anatomic or the intramedullary axis and the mechanical axis of the femur is called the divergence angle. For total knee replacement planning, it is also referred to as the varus or valgus correction angle. On an average, it is 7 plus minus 2 degrees. Thus, when conventional intramedullary instrumentation is used for total knee replacement, using 7 degrees as VCA would normally lead to the joint line being in 2 to 3 degrees of valgus. While using 5 degrees as VCA would normally lead the joint line being perpendicular to the mechanical axis. This is also referred to as zero in technology assisted knee replacement, as it would be 0 degrees to the perpendicular to mechanical axis. Now moving on to tibia. The line joining the tibia knee center to the ankle center is the tibia mechanical axis. The mid-diaphyseal line of the tibia is the tibia anatomic axis. The proximal most points of medial and lateral tibial condyle are marked, and the line joining them represents the tibia knee joint line. The mechanical and the anatomic axis of tibia are collinear, and hence there is no divergence angle for tibia. The angle used for measurement between the mechanical axis of the tibia and the knee joint line is the medial one, and hence is called the medial proximal tibial angle. The knee joint line is in 2 to 3 degree of varus to the perpendicular from the mechanical axis. The normal relationship between the femur joint line and the tibia knee joint line is 0 to 2 degrees. So, in summary, for different reference axes important for alignments in total knee arthroplasty, firstly, the mechanical axis of femur and tibia are aligned as one straight line. Secondly, the femur knee joint line is in 3 degree of valgus to the mechanical axis, and the tibia knee joint line is in 3 degree of varus to the perpendicular to the mechanical axis. The VCA for the femur has to be 5 degrees to make the joint line perpendicular and 7 degrees to make it valgus to the mechanical axis. But we also need to keep in mind that a prosthetic joint has different biomechanics from the native joint. Hence, trying to restore normal anatomic alignment might not be a good idea for prosthetic joints. So after having seen the native normal alignment axis for the bone, let us see the described alignments for a prosthetic knee joint. The commonly used alignments for total knee arthroplasty are the following: mechanical alignment, which was the first to be described, followed by anatomic alignment, adjusted mechanical alignment, kinematic alignment, and restricted kinematic alignment. The aim of mechanical alignment for a prosthetic knee joint is to place it perpendicular to the mechanical axis of femur and tibia. It was the alignment propagated by the first developers of knee replacement and was a small trade-off between anatomy and the prosthetic joint biomechanics to ensure both longevity and function. The bone resections are performed for femur and tibia perpendicular to the mechanical axis. Hence, the mechanical lateral distal femoral angle is 90 degrees instead of the anatomic 87 or 88. Similarly, the medial proximal tibial angle is 90 degrees instead of the anatomic 87. The VCA was kept at 5 degrees to ensure perpendicular cuts. This also made the instrumentation easy as the cuts were performed at 90 degrees to the mechanical or the vertical axis. With anatomic alignment, as the name suggests, the joint lines are recreated along the anatomic lines. It was propagated by Hungerford and Krakow in the 1980s. The advantage of anatomic alignment is that the joint becomes parallel to the ground while walking as the leg adducts. The bone cuts required to recreate the anatomy require 3 degree varus for tibia and 3 degree valgus for the femur, which is difficult for most eyes. Also, as the instrumentation remains the same, it is a little more technically demanding. Restoring to purely average normal anatomy or purely mechanical alignment may have ensured longevity, but function can be compromised. Hence, there was a need for an alignment to answer to the functional demands of the knee. The aim is a well-balanced TKR throughout the range of motion. It is aimed to restore normal knee function by aligning the distal and posterior femoral joint lines of the femoral component to those of the normal or the pre-arthritic knee. By restoring these distal and posterior joint lines, we hope to restore the joint back to its normal or pre-arthritic functional axis. To restore distal and posterior joint lines, calipered thickness of distal and posterior femoral resection is performed, correcting for cartilage and bone wear. Thus, the thickness of the components will restore the natural distal and posterior joint lines for that patient. Thus, the principle is to remove bone equivalent to the metal being replaced after compensating for wear. No ligament releases would be necessary and a full and better function can be restored. But this will work only if the ligaments are normal and one is dealing with not very advanced arthritis. Similarly, newer total knee designs which mimic natural anatomy may be more conducive compared to the standard which follow a different biomechanics. Total knee designs are different. Some have a single mediolateral radius, some have a single sagittal radius, while some are multi-radii. Similarly, even in the native knee, not all knees follow the same radii of curvature. Hence, while there is a laudable attempt to get closer to natural anatomy and improve function, occasionally the premise might not hold true. Taking a quick review of literature, this kinematic natural alignment was found to be non-inferior at 6 years in the hands of the originator. But a recent randomized controlled trial showed no difference in functional results at 5 years. It was important to note that the results in both groups were within 3 degrees from the mechanical axis. Other authors have shown that there is poorer survivorship with residual varus. We have seen that mechanical and anatomic alignments use angles and conventional instruments to reach their goal. Kinematic alignment uses calipered cuts to restore joint lines, which possibly represents the zenith of measured dissection. But as we have seen, good results are the ones where the final axes are within plus minus 3 degrees or 5 degrees from the neutral. Another offshoot from the traditional alignments has been the adjusted mechanical alignment. It is an adaptation of the conventional mechanical alignment technique with the goal to undercorrect the constitutional varus or valgus to a maximum of 3 degrees. It was popularized by the Belgian group. There have been reports in favor as well as against this. A study of 132 consecutive varus knees with an average follow-up of 7.2 years had better functional results when the end varus was between 3 to 6 degrees. But another group had contrary findings. Yet another offshoot has been the restricted kinematic alignment. In patients with greater deformities, restricting kinematic alignment to within 5 degrees from the neutral mechanical axis has been advocated. Given the tight control required, it would need a technological aid in the execution of surgery. We have discussed the varus valgus alignment in the coronal plane, but moving the femoral component and the tibial component laterally also falls in the purview of the coronal plane alignment. Moving the center of the component laterally puts the axis in valgus and hence the components in relatively small varus for both femur and tibia. It also helps to improve the patella kinematics. In all, we have seen 5 different described alignments for total knee components. Let us look at the strengths and weaknesses, starting with the oldest, mechanical alignment. It is easy to perform with standard instruments, adequate releases are necessary, and the overall function is good and time tested. With anatomic alignment, femur is in valgus and tibia is in varus. The advantage is that the joint line becomes parallel to the ground while walking. The releases required decrease and the function is better, but it is a more demanding technique with conventional instruments. Adjusted mechanical alignment undercorrects up to 3 degrees to restore some constitutional varus or valgus. The joint line would not be parallel to the ground in walking, but probably that is what the person has been used to over the years. Full correction is not required, so the releases needed are lesser and the return to function is easier. Kinematic alignment relies on restoring the joint lines, but the overall coronal alignment falls within 3 degrees of the neutral for that individual. It is technically more demanding, but the amount of releases required are minimal, and hence the return to function is superior. Restricted kinematic alignment is within 5 degrees of the neutral, and the overall mechanical axis is still within 3 degrees of the mechanical alignment. So if we were to focus on the deviation from the neutral for all 5 described alignments, it is evident that all are within 5 degrees from the neutral of mechanical axis alignment. If we perform simple trigonometric calculations to look for a 5-degree error margin from the neutral, the foot would move maximally 4 centimeters for a 5.5-foot individual. It is indeed a very narrow landing strip with a very small margin of error. If we were to make a target for shooting, the center would be the mechanical axis at 0. Surrounding it in the 3-degree radius would be the anatomic alignment, adjusted mechanical alignment, and kinematic alignment. The outermost circle of 5 degrees would be the restricted kinematic alignment. So, if we were to follow a simple algorithm, we aim for the bullseye at 0 and name the alignment achieved in the 5-degree error margin as our desired goal. Coronal plane alignment is the easiest to study on post-operative X-rays, and hence it has been the most widely discussed. but there are many other variables affecting function and end results. From the various described alignments, it's obvious that there is not much differentiating the alignments, and probably we are missing the woods for the trees. Focus on the larger goal of overall alignment in all planes and remain within 5 degrees of the neutral, probably with some undercorrection. In terms of difficulty, we have seen that focusing on the mechanical is probably the easiest to follow. TKR is a soft tissue surgery. Why increase the level of complexity at the bone level? Besides, ligaments may not be normal, so safer to aim for the straight, narrow, and easier. It seems logical that lesser the amount of release required, easier is the return to function. But both inadequate releases and over-enthusiastic releases should be avoided. The best possible option would be to optimize and individualize preoperative planning with 3D templating to achieve maximum benefit with minimum insult. With 3D planning, it is possible to individualize alignment, see the overhang, and medialize or lateralize, and would be able to match the trochlear groove as well as see different sizes and designs to find the perfect match. One can see in 3D how the knee lines up with the normal curvatures of the bone in all three planes. "3D vision is the art of seeing what others don't." Thank you.